I take pride in continuing to play a role in the Department of Ophthalmology at King Saud University. After 3 decades as member of this department, I'm now joining the department as Professor Emeritus, and I take pride in this appointment that was given to me by the Dean of the College of Medicine at King Saud University. Today, we are going to discuss the subject of infectious uveitis. I'm going to focus first on certain aspects of emerging infections and later focus on the spirochetes as a cause of uveitis in man. I'm also proud of the 9 books that we have published during my tenure at the Department of Ophthalmology, King Saud University. These are the 9 books that are related to infections of the eye, and they can be of great support to you during your study on infections of the eye that can cause blinding disorders. The last book that we published is by Springer Verlag, and this is on ocular infections. And Infections of the Eye is the second edition by Butterworth, Heinemann, Lippincott. These books are related to diagnostic microbiology and cytology of the eye, as well as posterior uveitis by infectious and non-infectious diseases. And there is a book on infectious diseases that may be of help to you. These are International Ophthalmology Clinic books on immunologic diseases and posterior uveitis, part 1 and part 2, that are related to infections of the eye. So I hope you will find them useful for you. In the last century, there was a widespread false optimism that sanitation, antibiotics, and vaccinations are going to conquer infections. Unfortunately, this concept proved to be elusive, and infections are still common causes of inflammation and blinding disorders of the eye. Wars and civil strifes come and go. Infections are going to stay with us forever. Certain infections have been eradicated by vaccinations, such as smallpox, shown here, among the last epidemic that was reported in Bangladesh. However, there are other infections that have been controlled by public health measures as well as antibiotics. Uveitis in general can be classified into 3 groups based on the etiology: the infectious uveitis, the non-infectious uveitis, and the masquerade diseases that appear like uveitis but actually is caused by other diseases such as CNS lymphoma, for instance, that can present and as a uveitis. And in fact, it is not related to the uveitis, but rather a masquerade syndrome. Infectious diseases can be the classic infections such as tuberculosis and syphilis, but there are emerging infections, and we are living one of them that has caused the COVID pandemic. Now, as medical scientists, we have the unique role to dispel the mystery of uveitis and replace speculations with certainty and fiction with facts in order to arrive at an accurate diagnosis and find appropriate therapy for these disorders. Mistaken in infectious disease for non-infectious cause can become and can be catastrophic because infectious diseases require antimicrobial agents or antiviral agents, while immune-mediated disorders require immunosuppressive agents. So if you mistaken the diagnosis of an infectious cause for non-infectious cause, this can lead to disasters and should be avoided. It's our role to find the exact cause of uveitis and rule out infectious uveitis in order not to use immunosuppressive therapy and cause further harm to injury. Now, the World Health Organization has proclaimed that the 21st century is the emerging infectious diseases century with a global alert and global response. And new health system has been established by the WHO to witness and to prevent the pandemics as has been going on at the present time. We're living in a global village, and this global village can be affected. Globalization is not always social, political, and economic, but it can be in health and disease. And what happens over the past half a century, that has been disruption of the geographic barriers by air travel, and geographic diseases do not occur anymore. A disease in the jungles of Africa can jump into the urban communities of Europe in less than few hours. And therefore, the world and the global village are suffering from a global health problem. Growth and development increase the consumption, and this causes disruption of the ecosystem and can allow certain viruses to discover the human species. Global warming is due to the activity of man on this planet. And global warming and climate warming is causing major changes, not only economically, but also in health. Deforestation, like what's happening in Brazil, is exposing us to new organisms, and new diseases are emerging. There is wide use and abuse of antibiotics, which is allowing the emergence of new antibiotic-resistant organisms, and the wide use of biologics, which are sometimes essential for the treatment of uveitis in diseases like infectious diseases. These are increasing with the wide use of immunosuppressive agents. During our lifetime, we have witnessed the emergence of newly discovered microbial pathogens in humans. These are new diseases that we did not know about or we discovered the cause of. And the Nobel Prize for several of these diseases have been awarded in recent years. Guillain-Barré has been identified as caused by Campylobacter jejuni. Toxic shock syndrome is caused by Staph aureus and Strep pyogenes. Chronic post-cataract uveitis may be caused by P. acne. And peptic ulcer, which we used to be due to multiple risk factors, Now we are certain that it is caused by Helicobacter pylori. And the treatment of this condition is the use of systemic antibiotics. We used to call the cause of hepatitis non-A, non-B, but now we know it's caused by hepatitis C virus. And as you know, the Nobel Prize in 2020 was awarded to Dr. Alter, Houghton, and Rice, who discovered hepatitis C virus as the hepatitis virus that causes non-A, non-B. Ancillary bacillary angiomatosis is caused by Bartonella Hansley. We didn't know what cat scratch disease before, but with the AIDS epidemic in the 80s and early 90s, there was epidemics of bacillary angiomatosis and cat scratch disease, which now we know is caused by a bacterium known as Bartonella Hansley, which can be an important cause of neuroretinitis. The virus known as Synombra virus is now identified as the hantavirus, whilst Kaposi sarcoma is caused by herpes virus type 8. Acquired immune deficiency syndrome, of course, HIV 1 and 2 are the cause of AIDS, and this may also affect the eye. T-cell lymphoma has been recently recognized to be caused by human T lymphocyte virus. And Lyme disease, which was called Lyme because of the county known as Lyme in Connecticut in the United States, is now well known to be caused by a spirochete known as Borrelia burgdorferi. Whipple's disease is caused by Trophorema whipplei, and SARS is caused by coronavirus as well as COVID-19, which is causing our pandemics and has changed our lifestyle worldwide. In 1994, I wrote an editorial in the Annals of Saudi Medicine, and I said at the time, emerging infections pose a serious threat in humans. There is trouble ahead with new viruses at our doorsteps. Previously unknown viruses are coming our way and discovering the human race. I also continued to say, no one knows how many emerging viral infections are going to be found. And when an ecological system suffers degradations, such as the rainforests undergoing destruction, many species die out and survivors undergo population explosion. Wild unchecked viruses can adapt, react to change, mutate, and can jump species as it's presumed with the coronavirus coming from bats to humans. Emerging infectious diseases should now be considered in our differential diagnosis of known classical infections that can cause uveitis. Viruses can adapt, change, mutate, and jump species. And they can be an important cause of infectious uveitis. There is constant pressure on the medical community because of these pandemics that are coming our way. Now, when we discuss infectious uveitis, I like to discuss it based on the host. Is the host immunocompetent or immunocompromised? Because the causes of infectious uveitis in the host can be different from immunocompetent host to immunocompromised host. Immunocompetent hosts may be affected or infected by bacteria such as spirochetes, mycobacteria, which were discussed by Dr. Abul Asrar last week, nocardia, meningococcus, brucella, serratia, and bacillus species. Fungal infection can be caused by aspergillus in the immunocompetent host, as well as viruses can be caused by herpes zoster and herpes simplex. Parasites that can cause infectious uveitis, in fact, it is the most common cause of infection of the retina. It is Toxoplasma gondii. Other emerging infections are Rift Valley fever caused by the Bunya virus, rickettsia caused by rickettsia species, and West Nile virus, which is a virus caused by flavivirus. Now, the immunocompromised host may be affected, and infectious uveitis in such a host may be caused by a bacterium known as Mycobacterium avium intracellulare, fungi such as Candida and Cryptococcus, viruses, CMV, cytomegalovirus, can cause disease in the immunocompromised host, as you well know, and parasites can cause toxoplasmosis in the immunocompromised host as well. Now let's go to the spirochetes, and today I will try to focus on the spirochetes. The spirochetes, the five spirochetes that are important for us and can cause infectious uveitis are Treponema pallidum, Treponema pallidum endemicum, Borrelia burgdorferi, Leptospira interrogans, and Leptospira biflexa. Each one of those can lead to uveitis that may simulate immune-mediated uveitis, and we have to rule them out in certain conditions in order not to miss an infectious cause of uveitis. Now, let's take Bejel. Bejel is an Arabic word for a disease that affects the skin and the mucous membrane as well as the internal organs. The primary lesions occur by mucus patches of the mucous membrane. In fact, the primary lesions are transmitted by sharing cups from one person to another and drinking unpasteurized milk and sharing vessels from between individuals can cause transmission of the disease and mucus patches. This is followed by the papillary eruption, and the moist lesions on the mucocutaneous surfaces may lead also to skin folds. Now, we studied 17 cases of Bejel. Bejel occur most frequently between Medina and Tabuk in the northwest part of Saudi Arabia. We studied 17 cases of Bejel, and we found out of the 17, 2 cases that had saddle nose and destruction of the nasal cartilage, as you can see in this patient. Both of these patients had uveitis. In fact, cartilage, but also in this patient had phthisis bulbi on the right eye, and therefore the patient developed uveitis due to Bejel and ended up in phthisis bulbi. The patient had also uveitis in the left eye. Those 8 cases with Bejel that we took X-ray of the tibia, 5 out of the 8 had evidence of pericystitis, which is a common manifestation of Bejel, and thickening of the periosteum and bowing of the tibia. And these are manifestations, systemic manifestations of Bejel. Out of the 17 cases, the 17 patients had uveitis, and all 17 patients had, in fact, panuveitis. They had positive luetic serology. And you cannot differentiate the lytic serology between Treponema pallidum of syphilis and Treponema pallidum endemicum of Bejel. Posterior uveitis and anterior uveitis can occur in patients with Bejel. It can be non-granulomatous and sometimes granulomatous, leading to posterior synechia as shown here. But you can also have chorioretinitis. These bone spicules were not due to retinitis pigmentosa. These were due to Bejel, and the patient, in fact, um, had normal ERG and normal EOG. And these bone spicules are a manifestation of pseudoretinitis pigmentosa due to Bejel. Syphilis is a disease which is coming back, and there is evidence of an increase in the incidence of syphilis in the Western Hemisphere. It is caused by the spirochete Treponema pallidum. It's a spirochete, which is motile. It's coil-shaped and elongated and measures 0.1 to 0.2 micrometers by 5 to 20 micrometers. You cannot see it by regular microscopy, and it has to be seen by uh, dark microscopy. Syphilis can be of two types, a congenital transmission or acquired. The types of acquired syphilis can be primary, where you get a chancre, or secondary syphilis. The primary occurs in the genital area, and around 6 weeks later, you get the secondary syphilis. Latent syphilis can occur as well as tertiary syphilis, where you have gamma formation. And neurosyphilis can occur with or without symptoms. And this can stay, the spirochetes can stay viable in the central nervous system throughout the life of the individuals. Now, the ocular manifestations of secondary syphilis includes anterior granulomatous uveitis, roseola of iris, Kepi nodules, Busaka nodules, choroiditis, retinitis, juxtapapillary chorioretinitis, retinal vasculitis, and papillitis. Syphilis is known as the great mimicker, and in fact, in the posterior segment of the eye, it may mimic herpetic retinitis because it can cause chorioretinitis, it can cause necrotizing retinitis, it can cause vasculitis as well as papillitis. Tertiary syphilis causes chorioretinal infiltrates and vitritis as well as papillitis, optic neuritis, and necrotizing retinitis, especially in patients with AIDS. This is a 27-year-old male who presented to me, referred by an ophthalmologist, in fact, who made the correct diagnosis of an anterior granulomatous uveitis. You can see here the evidence of the KPs that are medium-sized, and they are the cause of granulomatous uveitis. The patient was on topical steroids, and therefore there were only 2+ cells and 2+ flare, but because of the topical steroids that he was on, the cells and flare were decreased. And this is typical. Sometimes granulomatous uveitis can be changed to non-granulomatous because of the use of topical steroids. One has to be careful and take the appropriate history of topical steroids when you are evaluating granulomatous or non-granulomatous uveitis. The patient we did serology, and they had positive serology for VDRL, as well as quantitatively, there was one in over 3,000 titer for Lewis for syphilis. This is the other eye of the same patient, and the patient had granulomatous uveitis despite the use of topical steroids. When we looked at his arms, and this is again the granulomatous uveitis seen with the positive serology, the patient had papillomacular eruption. You can see the scaly lesions. These scales in patients with syphilis carry spirochetes. And if you rub these, you will have millions of spirochetes on your hand. In fact, the soles had the same lesions with scaly lesions, and the patient had also palmar rash. Palmar rash occurs in only few cases in meningococcus, in patients with rickettsia, and in patients with syphilis, and sometimes it can occur in meningococcus skin eruptions. So palmar rash is not a common manifestation. It occurs only in few skin conditions. But keep in mind that palmar rash is a manifestation of secondary stage of syphilis. And you should not shake hands. If you do, you have to wash your hands very carefully in order not to have shedding of the spirochetes on your hands from syphilis. This is another patient with positive serology, and you can see the vitritis. You can barely see the outline of the optic nerve. It's we call it the headlight in the fog appearance because of the severe vitritis associated with syphilis. Keep in mind that necrotizing retinitis may occur in syphilis, and you can see the evidence of vasculitis in this patient here and maybe here. And this type of vasculitis leads to necrosis. The necrosis simulates and appears like herpetic acute retinal necrosis syndrome. So one has to be careful in making the diagnosis. One will have to be, you can see the vasculitis over here. One can be treated with systemic penicillin, such as secondary stages of syphilis, while herpes, you have to give antiviral agents, and this is completely different management plan. This is another manifestation of syphilis, and this is what's called the so-called placoid chorioretinopathy. It's like a placoid at the level of the retinal pigment epithelium. And you can see the vessels of the retina, and you can see the retinal pigment epithelium with the placoid lesions. It's always in the posterior segment of the eye, and sometimes these are missed, and sometimes AMPI is diagnosed instead of syphilis. One has to be very careful and do lytic serology in order to rule out syphilis in this patient with the placoid chorioretinopathy. Now, Treponema pallidum causing syphilis cannot be cultured. You have to detect it by dark field microscopy or non-specific antibody testing, such as the RPR or the VDRL, or you can do specific treponema antibody testing, such as the FDA and the MHT. FDA, the fluorescein treponema antibody testing, and the microhemagglutination test for syphilis. Both of these are specific treponema antibody testing, and they can be helpful in making the diagnosis of syphilis. Now, the lab diagnosis includes the FDA-IBS, as we said, VDRL, TPHA, HIV serology, as well as lumbar puncture, which has to be done to rule out neurosyphilis. Treatment of acquired syphilis, primary syphilis, consists of benzathine penicillin G, 2.4 million units intramuscularly once as recommended by the CDC. Treatment of acquired syphilis in adults, there are alternate drugs. One can give doxycycline 100 milligrams orally twice daily for 14 days, or you may use azithromycin 500 milligrams orally for 14 days. Now, another spirochete, which is important for us, is Lyme disease, and this is caused by Borrelia burgdorferi. Borrelia, because it's for the group Borrelia, the spirochetes, Borrelia, and Burgdorferi because Professor Burgdorfer, who was living in Colorado and isolated the Borrelia from ticks that cause the vector that transmits the Lyme's disease. The vector or the ticks most commonly is Ixodes damini, but you have Ixodes pacificus and Ixodes racinus, as well as Ixodes persulatus. Ixodes damini is in the eastern part of the United States, especially in the New England states of the United States. And Ixodes pacificus is found in the west part of the United States. Ixodes racinus is found in Saudi Arabia and in Europe. Ixodes persulatus, it is found in northeastern Europe and northern part of Asia. And you can see Lyme disease in all these areas where Ixodes is found as the vector for Borrelia. The primary disease or stage 1 of the disease of Lyme disease, which occurs from day 1 after the bite of the Ixodes to 30 days after the bite. It causes erythema chronicum migrans, which is skin lesions. I'll show you pictures of. It may lead to conjunctivitis in the primary stage of the disease, and it may cause episcleritis. Now, in stage 2, you have the period is from 2 months to 3 months. And during this stage, you may get cranial nerve palsy, such as facial palsy, myositis, ataxia. AV block is a common manifestation of Lyme disease in this stage, and polyarticular arthritis. In fact, when the arthritis was first discovered in Lyme County in Connecticut, it was called JIA-like arthritis, but it can also cause anterior non-granulomatous uveitis, as well as choroiditis. Optic neuritis may occur, strabismus because of the cranial nerve involvements, pars planitis with snowballs, and intermediate uveitis with retinal vasculitis. All these are manifestations and mostly in the second stage of the disease. In the third stage of the disease, you may get aseptic meningitis, arthritis, which is rheumatoid-like, and keratitis as well. This is just to show you an ear, and you can see a very small tick in the ear. So you may not be able to recognize this lesion, this tick. It's a very tiny tick that transmits Borrelia from reservoirs, usually deers, to man. And this is the same tick under microscopy. And the spirochetes, the Borrelia is a spirochete which is coiled, and this is an immunofluorescent stain showing the Borrelia burgdorferi. This is what we call the target lesion. This is the lesion here. The bite is here, and you can see the the rings of the bites. This is the first ring, and this is the second ring here, and this is the lesion migrans, which occurs after the skin bites, causing rings of waves, and this occurs within the first month after the bite with the exodus tick. Now, this is the arthritis that you see in young adults, and you can see the swelling, and sometimes it looks like rheumatoid arthritis. Patients may develop snowballs, as shown here, and you can get peripheral retinal vasculitis due to borreliosis. Borreliosis is Lyme disease. The lab findings in Lyme disease includes IgG and IgM antibodies to Borrelia burgdorferi, which can be diagnosed either by ELISA or by immunofluorescence. PCR can diagnose the disease, and you have to keep in mind that you may get false positive with the ELISA if patients have syphilis or rickettsia, and sometimes the false positive can occur in some other patients as well with autoimmune diseases. In patients with Lyme disease, the treatment consists of, depending on which stage, in stage 1 and stage 2, you can give them doxycycline or amoxicillin or azithromycin. But in the third stage of the disease, it becomes more resistant to treatment, and one has to give intravenous penicillin or intravenous ceftriaxone in these patients. Otherwise, they will not have a cure of the disease. Now, I would like to try to discuss another spirochete, which is leptospirosis. It's an interesting spirochete, and it is common in nature and in reservoirs, in animal reservoirs. The leptospirosis is the most common cause of uveitis in horses. So if you have a horse with uveitis, you have to rule out leptospira until proven otherwise. The cause is Leptospira interrogans or Leptospira biflexa. Biflexa is much less common. The most common is Leptospira interrogans. And the organism measures 6 to 20 micrometers by 0.1 micrometers. It has hooks, and the spirochetes is motile, can be detected by dark field microscopy. It cannot be seen by our light microscopy. And you can do silver staining, or like I showed you with fluorescent antibody staining as well. PCR can be done for the diagnosis of leptospirosis. There are two forms, one a serious form which is fatal, and one which is a mild form. The mild form is anecteric. It means there is no jaundice in this form of the disease. Or ecteric. Ecteric, these patients may develop hepatitis and develop jaundice. It's the severe form which can be fatal in some patients. Now, leptospirosis is a zoonotic disorder. A zoonotic disorder is a disease uh, that is transmitted from animals to man. And the reservoir of leptospira are the rodents, the dogs, the cats, the birds, and the horses. Horses can be also a reservoir of leptospira. The transmission is from direct contact with urine, blood, or tissue of infected animals. Spirochetes enter the skin with abrasions or enter the mucous membrane. So remember that if there is urine in water, you might get it by indirect transmission from one person to another. And this is what happens in India. When kids are playing in stagnant pools, you may get transmission of the disease from one person to another. This is a patient with leptospirosis. The patient had non-granulomatous uveitis. And this, keep in mind that non-granulomatous uveitis can be a manifestation of an infectious uveitis. You can see the posterior uveitis, posterior synecdoche at 6 o'clock, which is a common place for fibrin to settle and cause the adhesions. And this patient had an anterior uveitis, which was non-granulomatous. Leptospirosis it may first like anterior uveitis, and sometimes you may get a hypopion with it. And the patient may develop vitritis as well. Retinal vasculitis is a common manifestation in patients with leptospirosis, and you have to put it in your differential diagnosis. This is a patient with leptospirosis showing the hypopion, and thus some of these patients with leptospirosis may develop hypopion. I am showing this to show you a partially absorbed cataract. And this happens in patients with severe uveitis due to leptospirosis. The leptospira appears to enter the lens and cause reabsorption of the lenticular matter, and therefore sometimes you end up with only posterior capsule and anterior capsule against each other because of absorption of the mature cataract associated with leptospirosis. Why doesn't it happen with other type of spirochetes? I don't know, but it is one of the manifestations of patients with leptospirosis. Leptospirosis, as I mentioned, can be caused by Leptospira interrogans or Leptospira biflexia. 90% of the cases are due to Leptospira interrogans. This is a posterior segment shot of a patient with systemic leptospirosis, and the patient has evidence of retinal vasculitis. There is evidence of retinitis here, and this affects the inner layers, the outer layers of the retina. You can see the hyperemia of the optic nerve head with evidence of peripapillary chorioretinitis here. And this is a typical manifestation of a vasculitis in patients with leptospirosis. Another patient showing the leptospirosis, which can be beaded. The vasculitis in leptospirosis can be beaded, and you can see here the multiple lesions of retinal vasculitis due to leptospirosis. Now, the septic phase of the disease is characterized by fever, headaches, myalgia, and it may cause death because of renal failure in some of these patients. In the immune phase, where the patient develops immunity against leptospirosis, then you may get headache, aseptic meningitis, which may last anywhere from 7 to 30 days. you may get skin rash, hepatosplenomegaly. 10% are the ecteric form, and which are the severe form, which ends up in renal failure and sometimes renal failure lead to death. So if you get a patient with infectious uveitis, you have to rule out leptospirosis in some of these cases, especially if they are coming from endemic areas. The treatment of leptospirosis consists of amoxicillin or doxycycline or penicillin G. And the treatment should be continued usually we don't stop the treatment before 1 month. So in conclusion, we can say that infectious uveitis is not uncommon. It's becoming a more common and a serious problem in patients, in some of the patients. We should not rest on the laurels we won in the conquering of classical infection, but we should be prepared for the fight against the pandemics and the coronaviruses and other types of viruses that are jumping species and exploring mankind and causing harm and death and patients' loss over the past few years. We should be prepared to find new ways to diagnose, new ways to treat, and new ways to prevent infectious uveitis. Thank you.